Spine. Congenital. Congenital Arnold-Chiari malformation syringomyelia/hydromyelia. Tethered cord. Arnold-Chiari malformation. Description. Arnold-Chiari malformations consist of a spectrum of congenital anomalies that affect the hindbrain. They are characterized by a downward elongation of the brainstem, medulla oblongata, cerebellum, cerebellar tonsils, and the fourth ventricle into the cervical portion of the spinal cord. Arnold-Chiari malformations are categorized into three types. In an Arnold-Chiari type I, the cerebellar tonsils along are displaced 5 to 6 mm or more below the foramen magnum. There is no hydrocephalus involved and the fourth ventricle remains in its normal location. A syringohydromyelia, syrinx, of the cervical spinal cord may be seen. This may be associated with Klippel-Feil syndrome. In an Arnold-Chiari type II, the cerebellar tonsils and vermis of the fourth ventricle, cerebellum, and medulla oblongata have herniated down through the foramen magnum into the cervical spinal canal. Obstruction of the fourth ventricle results in hydrocephalus. This type is associated with myelomeningocele and agenesis of the corpus callosum. In an Arnold-Chiari type III, malformation is characterized by displacement of the cerebellum meninges, and sometimes the brainstem into an encephalocele. Encephaloceles result from a herniation of the brain or meninges, or both, through a skull defect. Characteristics seen in type II Chiari malformations may be present. It occurs in approximately 1 in 4,000 to 5,000 deliveries. Etiology. Type I Arnold-Chiari malformations are found more often in adults, incidentally by MRI, than in children. There does not seem to be any gender preference. Epidemiology. The prevalence for AD is less than 1% before the age of 65, however, this quickly increases to 10% of the population over the age of 65 and between 30% to 50% over the age of 85 years and older. There seems to be a higher prevalence in women than in men. Signs and symptoms. Hydrocephalus and developmental defects may be seen early on in infants. Young adults may be asymptomatic until neurologic deficits such as craniocervical junction abnormalities, e.g., progressive ataxia, occur. Imaging characteristics. MRI is the modality of choice for diagnosing this disorder. CT. The effectiveness of demonstrating the anomaly with CT is limited due to the bony surroundings and axial imaging. MRI. T1 and T2 weighted pulse sequences will demonstrate the downward herniation of the cerebellar tonsils through the foramen magnum into the upper cervical canal. Associated findings may include syringomyelia and hydrocephalus. Treatment. Surgery intervention may be used to decompress the posterior fossa. Shunt placement is used to treat hydrocephalus. Prognosis. Depends on the type, age of the patient when diagnosed, and extent of other related developmental defects. The prognosis for infants may be worse than for adults. Figure 1. Arnold-Chiari malformation. T1 weighted sagittal image demonstrates downward herniation of the cerebellar tonsils, arrow, through the foramen magnum into the upper cervical spinal canal with compression of the medulla oblongata. Syringomyelia/hydromyelia. Description. Syringomyelia refers to any fluid-filled cavity within the spinal cord. A cavity in the cord may be due to central canal dilatation, hydromyelia, or a cavity eccentric to the central canal, syrinx. It is difficult to differentiate between these two entities. Etiology. Approximately 50% of syringomyelia are congenital, Chiari malformation. Acquired cases are the result of intramedullary tumors, trauma, infarctions, and hemorrhage. In some cases there is no known cause. Epidemiology. Approximately 90% occur in associated with an Arnold-Chiari type I malformation, but also may include myelomeningocele, basilar skull impression, platyphasia, atresia of the foramen of Magendie, or Dandy-Walker cysts. Signs and symptoms. Depends on the extent of the syrinx. The patient may experience sensory loss, loss of pain and temperature, muscle atrophy, lower neck, shoulders, arms, and hands, and thoracic scoliosis. Imaging characteristics. MRI is the modality of choice for diagnosing of syringomyelia. CT. Post-myelogram CT demonstrates a contrast-filled syrinx surrounded by the hypotenuse spinal cord. MRI. Signal intensity of a syrinx may be iso-intense to CSF on T1 weighted images. Signal intensity of a syrinx would be iso-intense to CSF on T2 weighted images. Treatment. Surgical drainage of the syrinx is the suggestive treatment. Prognosis. Variable, depending on the extent of the syrinx. Figure 1. Syringomyelia. A. B. Sagittal T1W, A, shows abnormal low intramedullary signal and cord expansion. The abnormal fluid within the spinal cord is hyperintense on the sagittal T2W image, B. Figure 2. Syringomyelia. Axial T2W of the cervical spine shows hyperintense fluid in the spinal cord, arrow, consistent with a syrinx, tethered cord. Description. A tethered cord is a condition in which the conus medullaris is prevented from ascending to its usual position at the level of L1-L2. It is tethered at an abnormally low position by a tight, short, thickened filum terminale, fibrous bands, interdural lipoma, or some other interdural abnormality. Etiology and epidemiology. This congenital abnormality is seen in neonates. Signs and symptoms. Patient presents with muscle weakness, abnormal lower limb reflexes, bowel and bladder dysfunction, back pain, and scoliosis. Imaging characteristics. MRI is the modality of choice for diagnosis of a tethered cord. MRI. Tip of the conus medullaris is below the level of L2. T1 weighted axial shows a thickened, greater than 2 mm in diameter. The conus medullaris may be tethered by a spina bifida occulta and/or interdural lipoma, posteriorly displaced by fat, glial cells, and collagen. Treatment. Surgery in infancy or early childhood is required to prevent progressive neurologic deficit. Prognosis. Depends on the extent of the tethered cord and the age of the young child at the time of diagnosis and treatment. Figure 1. Tethered cord. Axial contrasted CT scan through pelvis shows abnormal fat density within the sacral spinal canal consistent with terminal lipoma. AB Figure 2. Tethered cord. Sagittal T2W, A, and coronal oblique T1W, B, images through lumbar spine demonstrates thickened terminal filum in the terminal lipoma. Note, extension of fat through spinal dysraphism into spinal canal. Spine. Degenerative. Degenerative. Herniated disc. Spinal stenosis. Spondylolisthesis. Herniated disc. Description. A herniated disc is also referred to as a ruptured or protruded disc. A herniated disc occurs when part or the entire nucleus pulposus, the soft, gelatinous, central portion of an intervertebral disc, is forced through the disc's weakened or torn outer ring, annulus fibrosus. This extruded herniated disc may impinge upon spinal nerve roots as they exit from the spinal canal or on the spinal cord itself. Etiology. Herniated discs may result from severe trauma or strain, or may be related to intervertebral joint degeneration. In older patients with degenerative disc disease, minor trauma may cause herniation. Epidemiology. About 90% of herniated discs occur in the lumbosacral spine, with the majority of these occurring at L5-S1, and rest at either L4, L5 or L3, L4. A small percent of herniated discs involve the cervical spine, with the majority of these being at C5, C6 and C6, C7. Only 1% to 2% of herniated discs occur in the thoracic spine. Signs and symptoms. Patients with lumbosacral herniated discs will present with low back pain, radiating to the buttocks, legs and feet, usually unilaterally. Sensory and motor loss, muscle weakness, and atrophy of the leg muscles may be experienced if a lumbar spinal nerve root is compressed. Cervical disc herniations present with pain in the neck and upper extremities and weakness, and neurologic deficits, such as muscle spasms, numbness, and tingling are common symptoms. Imaging characteristics. As a result of excellent soft tissue resolution and multiplanar imaging, MRI is the imaging modality of choice for diagnosing herniated disc. MRI and CT demonstrate disc degeneration. Herniated disc usually lateralized to one side, compressing the thecal sac and nerve root. Free disc fragments may migrate superiorly or inferiorly. Treatment. Conservative treatment consists of bed rest, heat, exercise, and medication ranging from anti-inflammatory drugs to muscle relaxants. Patients not responding to conservative treatment may require surgical intervention. Prognosis. Prognosis is very mixed, dependent on the severity of damage, the quality and skill of surgical intervention, the age, size, and weight of the patient, and whether there is a physically active or sedentary lifestyle. T1 weighted sagittal MR image shows herniated disc at the L5S1 level. Figure 1. Herniated disc. T1 weighted sagittal MR image shows herniated disc at the L5S1 level. Figure 2. Herniated disc. T1 weighted axial MR image demonstrates right-sided herniated disc at the L5S1 level, compressing the right side of the thecal sac and nerve root. Figure 3. Herniated disc. T2W sagittal MR of L5S1 verify disc bulge. End plate hyperintensity about this disc space was degenerative. Spinal stenosis. Description. Spinal stenosis may be defined as the narrowing of the spinal canal in lateral recesses as a result of progressive degenerative disease of the disc, bone, and ligament. Problems arise when the spinal canal and cord is constricted. Mostly involves the cervical and lumbar spine. Etiology. Spinal stenosis may be categorized as either congenital, developmental, or acquired. Congenital spinal stenosis may be due to achondroplasia or anomaly, or may be idiopathic. Acquired central spinal stenosis may result from several manifestations including degenerative disc disease, ligamentum flavum hypertrophy, spondylolisthesis, bulging disc and trauma. Epidemiology. Most commonly found in the cervical and lumbar spine. Signs and symptoms. When the cervical portion of the spine is involved, the patient may present with a radiculopathy, myelopathy, or neck or shoulder pain. If the lumbar spine is affected, the patient may present with limping type of gait, neurogenic or spinal claudication, low back pain, or paresthesia of the lower extremities. Imaging characteristics. MRI is the modality of choice for diagnosing spinal stenosis. CT following myelography would be the next best choice for imaging spinal stenosis. MRI and CT. Narrowing of the spinal canal, lateral recess, and neural foramen. Bulging discs. Hypertrophy of facet joints and ligamentum flavum. Spondylolisthesis. Compression of the thecal sac and nerve roots. Treatment. Surgical intervention may be considered. Prognosis. This condition is progressive. Figure 1. Spinal stenosis. Sagittal CT, A, and T2 MR, B, images through the cervical spine demonstrate multi-level disc bulges, most notable at C5-C6, causing moderate canal stenosis, spondylolisthesis. Description. Spondylolisthesis is the displacement or slippage, either anterior or posterior, of a vertebra over an inferior vertebra, usually the fifth lumbar vertebra over the sacrum, or the fourth lumbar vertebra over the fifth, causing a misalignment of the vertebral column. Type I involves a 25% vertebral displacement over the vertebra that is immediately inferior to it. Type II a 50% vertebral displacement, and Type 3 is 75% vertebral displacement over the inferior vertebra. Type 4 involves anything over a 75% vertebral displacement over the inferior vertebra. Etiology: spondylolisthesis may result from acute trauma, congenital or acquired fibrous defects in the pars interarticular is, spondylolysis, or as a result of spinal instability due to degenerative changes involving the disc and facet joints. Epidemiology: spondylolisthesis occurs in 60% of patients with spondylolysis, which occurs in approximately 5% of the population. The L5-S1 interspace accounts for 90 of the cases of spondylolisthesis, with the majority of those cases being anterior displacement of the L5 vertebra. The L4-L5 interspace accounts for approximately 10% of spondylolisthesis cases, with most involving anterior slippage of L4 vertebra. Cervical spondylolisthesis comprises less than 1% of all cases. Signs and symptoms: patients may present with low back pain and/or stiffness and loss of function. Tight hamstrings may force the patient to walk with the knees bent and a short stride, causing poor posture or unusual gait. Imaging characteristics: plain films are usually sufficient to make the diagnosis. CT. Sagittal reformatted images demonstrate a shifting of a vertebra over an inferior vertebra. Shows pars interarticularis defects, spondylolysis. MRI. Shows forward slippages of one vertebral over another, best seen on a sagittal image. Shows other associated findings, e.g., degenerative disc disease and spinal stenosis. Treatment: conservative treatment is usually initiated to treat the patient's symptoms. Surgery may be indicated in symptomatic patients who do not respond to conservative treatment. Prognosis may vary depending on the type and other associated findings. Figure 1. Spondylolisthesis grade I. Sagittal T1 weighted MRI image of the lumbar spine demonstrate mild forward displacement of the L4 vertebral body over the L5. This is consistent with grade I spondylolisthesis. Degenerative changes of L4, L5 and L5-S1 discs noted. Figure 2. Spondylolisthesis grade 2. T1 weighted image demonstrates a forward displacement of the L5 vertebral body over S1 consistent with a grade 2 spondylolisthesis. Note, the degenerative changes of the L5/S1 disc. Figure 3. Spondylolisthesis. A. B. Sagittal CT, A, demonstrates traumatic, type 4, androlisthesis of C6 on C7 with bilateral jumped facets, not shown. Sagittal T2W Mr. B, shows androlisthesis and extensive ligamentous/soft tissue injury. Spine. Demyelinating. Multiple sclerosis, spinal cord. Description: multiple sclerosis, MS, is a demyelinating disease affecting the spinal cord. See the section Brain, multiple sclerosis. The areas of demyelination are commonly referred to as plaques. Multiple sclerosis may go through periods of exacerbation and remission. Etiology: the exact cause of multiple sclerosis is unknown, however, theories suggest a slow-acting viral infection and an autoimmune response. Other theories suggest environmental and genetic factors. Epidemiology: multiple sclerosis commonly involves the spinal cord. Rarely is MS seen in children and older adults. Females are slightly more affected than males. Signs and symptoms: patient present with focal neurologic attacks, progressive deterioration, and ultimately permanent neurologic dysfunction. Other complications include sensory and motor dysfunction. Imaging characteristics: MRI is the imaging modality of choice for the diagnosis of multiple sclerosis in the spinal cord. MRI. T1 weighted images are useful to evaluate the spinal cord morphology. T2 weighted images demonstrate the MS plaque as high signal. Post-contrast T1 weighted images demonstrate enhancement of active MS plaques. FLAIR images improve MS plaque detection by suppressing CSF signal near the spinal cord. Treatment: there is no specific treatment for MS. Corticosteroids and other drugs, however, are used to treat the symptoms. Physical therapy may help to postpone or prevent specific disabilities. Prognosis: the course of the multiple sclerosis disease process is varied and unpredictable. Figure 1. Multiple sclerosis. Sagittal T2 Mr. A. Image through cervical spine demonstrates a well-delineated hyperintense lesion in this patient with known mesaxial CT scan. B. At the level of the lesion shows no identifiable abnormality at that level. Spine infection. Vertebral osteomyelitis. Description: osteomyelitis is an inflammation of the bone caused by an infecting organism. It may be localized or spread through the bone to involve the marrow, cortex, periosteum, and soft tissue surrounding the affected area. Vertebral osteomyelitis usually occurs as a result of disc space infection. However, osteomyelitis may occur through hematogenous dissemination directly to the vertebral body. Pyogenic infections to the disc space are usually caused by a bloodborne pathogen from the lung or urinary tract. These pathogens get lodged in the region of the end plate of the bone and destroy the disc space and the adjacent vertebral bodies. Etiology: the majority, 90%, of all bone and joint infections are caused by the Staphylococcus aureus microorganism and may occur following trauma or surgery. Other common microorganisms include Escherichia coli and Proteus. Epidemiology: osteomyelitis can occur in any location and patients at any age. Patients who are particularly vulnerable include diabetics, steroid users who are immunosuppressed, those on hemodialysis, and drug addicts, particularly heroin. Signs and symptoms: patient presents with fever, malaise, pain, and swelling over the affected area. Imaging characteristics: MRI is the preferred imaging modality. A gallium scan or indium-111 labeled leukocyte scan can also be helpful. MRI. T1 weighted images show low signal intensity. T2 weighted images show high signal intensity. Post-contrast, fat suppressed, T1 weighted images show enhancement in bone due to abscess formation and juxtacortical soft tissue enhancement. Treatment: antibiotic treatment is required. Severe cases may also need surgery. Prognosis: generally good, with early diagnosis and effective treatment. Figure 1. Vertebral osteomyelitis. Axial, bone window, CT scan shows lytic destruction of the L4 vertebral body with abnormal enhancement involving the adjacent psoas muscles. Figure 2. Vertebral osteomyelitis. Post-contrast T1W fat-saturated axial, A, and sagittal, B, images through the lumbar spine demonstrate abnormal enhancement of L3 and L4 with extension into the psoas muscles bilaterally. Note: right psoas muscle abscess.